I'm just going to quickly kick off with a question to both of our speakers. And this is around specialized centers. So you heard a comment from Hassan Malik earlier on that ERCP is sometimes done in a non-specialized center. Are there advantages? What are the advantages? Should it only be done? Which ones should be done in specialist centers? And equally for pathology, how much of this is something that needs special center expertise?
So, thank you. I think it's a very important question, and we've talked about this, I think, at previous meetings, that there's clear evidence, mainly from surgical colleagues, but in endoscopy as well, that people that do a higher volume of cases tend to have more expertise. And of course, specialist centres can have access to more equipment. And a lot of the technology that I presented today is extremely expensive, in terms of capital investment. So actually replicating all of that kit all around the country in every centre that does ERCP is not sensible from a clinical perspective, from a training perspective, from a quality perspective, or from a financial perspective. So I think that a collaborative approach, as we always want to use, with networks, with centres that are not doing the volume or the complexity of work with the frequency that big centres are, joining networks and referring complex patients in is the right way forward. And I think that we're in a scenario where someone doing a suboptimal job is very, very hard to unpick. I think that is important, and I think that's the focus we have to have. I think also speed of access is much easier. We have an ERCP list every day. We have access to GA for 50% of our lists, and the other big centres have similar or even better access to GA. So that's what you have to have available if you're going to offer a responsive, high-quality service, and you can't replicate that everywhere. But I won't get any more into the politics and anything. Thank you.
Yeah, sure. I mean, all these points are common ground to us. And of course, if the procedures are being done in one centre, well, the pathology is going to be in one centre. It will follow. And I think it really has to be, I think particularly I like the spyglass biopsies. They're difficult. They are very challenging for pathologists, and you need to see a lot of them to know how hard you can push and when it's time just to say, no, this is as far as I go. And I know in our own department, they're often reported by the general GI pathologists, and I insist, at my age, I can do these things, that they're always reviewed by hepatobiliary pathologists. Even in a specialist department's own, it makes a difference if they're seen by hepatobiliary pathologists. But there's another downside to it, because there are are only a couple of us. If one of us goes away, we have a problem. Who does these things? So I think we need to really look at how pathology is organized to respond to this increasing centralization.
Thank you. Vincenzo.
Yeah, thank you. I have a question for both of professors. First one from Professor Wadsworth. I want to ask, in your opinion, what is the best approach for sampling in distal stenosis of a bile duct, in comprising RCP, EUS, and EUS FNB, and also cholangioscopy? What do you prefer among these three?
So I think if we can access the bile duct and the patient's having an ERCP, transpapillary biopsies give the best volume. So not the spy bite biopsies, big pediatric standard endoscopic biopsy forceps into the stricture give you the best yield, and they give you the best volume of tissue, because we're not particularly looking just for a cytological diagnosis. That might sometimes be all we get. We want to get bigger volumes of tissue to pass to Rob and his team. So that would be my first choice. If the patient doesn't need an ERCP, and we obviously want to avoid the risk of giving them ERCP-related pancreatitis, then I think EUS with an FNB sample would be my second choice, because the FNB cores we can get, and Rob might raise his eyebrows a bit, are generally very good and are normally adequate. It's very rare that they're inadequate. So I think number one would be biopsy forceps. Number two would be a FNB at EUS.
Okay, thank you. If I can second one or...
Let's go to Derek.
Yeah.
Sorry.
Thanks. To be honest, in Newcastle, we have a lot of spyglass, and we get very poor pathology specimens from there. So, Rob, I wanted to ask you, the pathologists, and Tim's here, the pathologists tend to share specimens with each other. Very often we'd get a pathologist saying, well, we just sent this up to Edinburgh to have a look at, or sent it down to London to look at. We don't get the same thing with us as clinicians. We don't share as much. And is it because we're just too macho, or why do you guys do it and we don't do that?
Well, I guess it's easier to send the slides down to Edinburgh than to send the patient down to Edinburgh, but it would be one answer. But I think there's a culture in pathology of sharing. I mean, and digital pathology will make that much easier. Then you won't only send it on to Edinburgh or London, you can share it with a panel of experts across the world. Yeah, and that's really how we have to go, because we need that kind of expertise. I'm a huge fan of digital pathology and AI and all that. But I think for the time being, the gold standard.
But we don't, for endoscopy, we don't need to send the patient. You need to pick up the phone and say to someone who's an expert, I've got this patient, should I do this here or should I send it to you? Right. And we still have the knee-jerk response of getting someone to shove a stent up someone who's got a hyalocholangio, cause trouble, and then send the patient when there's a problem. And I don't know why we don't have that culture. Or maybe we do, but we don't see it where I am.
Time for clinicians to self-reflect here.
I could just say that when we did an audit of biopsies sent to the HPB MDT from outside for internal review, and I should say when we review internally, I almost always show them with my other colleague, who's, because I value her opinion, and because I want to extend her experience, and she wants to extend my experience of sometimes quite rare conditions. We find about 20% of biopsies, there's a significant difference in the diagnosis with central review as opposed to what it came in with. Whether we're right or wrong, that's a slightly different question.
Vincenzo, again, and then Jesus.
Yeah, thank you, Professor Goldin. I want to ask to you, Professor, whether you think that the classification in small and large may be implemented in a daily practice in your work, and whether looking to the peritumoral tissue may help to classify the cancer. Well,
I can say we're just I've just been involved in reviewing the Royal College of Pathologists guidelines for reporting hepatobiliary cancer, and we are recommending that people make that distinction. There's more things we could do, but you just got to be a bit careful, what would be interesting and what people have to do. But I think that distinction is something that should be part of a routine practice. It's not difficult. Of course, there will be cases where you can't, it's intermediate, but that's true of all aspects of pathology. But I agree. I think it should be done. And just know what other people think.
Thank you. Maybe a final last question. This is for Professor Goldin. You know that during the last years, an increasing number of experimental models has been conducted or proposed for cholangiocarcinoma in vivo. My question for you is, according to your vision, how well these experimental models were characterized? Because you know that multiple cystic lesions look like tumors but are not malignant. And they are characterized as cholangiocarcinoma, so the people can start to use this model as a cholangiocarcinoma model, but it's not malignant. And this is a big limitation.
I can only echo your statement. I think many of the models are models of some kind of biliary tract disease, but don't match what we would call cholangiocarcinoma. That's why I was really calling on pathologists who have a clinical experience to look at the animal model things, because I think they are better placed to make that judgment. I think it's difficult. It's fascinating to look at genetically modified mice, for example, to see lesions that no one has ever seen before. It's absolutely fascinating. But I think, to be fair, to give me a very short answer, many of the models published are not models of cholangiocarcinoma.
Do we need consensus?
Consensus. Yeah, I think we do need consensus. But, the gold standard for everything is, pathologists can change any classification they like. If it doesn't affect natural history or response to treatment, it's a waste of space. Similarly, in the mice, if you can't demonstrate progressive disease, you can't demonstrate progressive disease. Pathology can only take you so far. So that's my view.
Thank you. Just another question to Rob. There's obviously a big interest now in molecular profiling of patients with biliary tract cancer. So just for the patients and the carers here, can you just give us a sense of when does their tumor sample then go for molecular profiling? How much is already done? How much is then done elsewhere, maybe? Just talk us through that.
Well, I can only give you, our own experience. I mean, this is always clinician-led. We will do our HER2 and our MSI and maybe one or two other things in special cases, but we really require the clinicians to say to us, this case is needed. Maybe it's part of a trial, then of course it's done automatically, but if there's some clinical reason to do it. We send it out. I have to say, Imperial's quite a big place, but we will send ours out, normally to the Marsden for the work, sometimes to Great Ormond Street. But we have to send it out, and I think that's part of the centralization process, that there are certainly in London, every medical school has its own molecular lab, and that's kind of going now, yeah.
And there's a question online from Marta Carpinelli. Will it be helpful to have samples from a latest patient? Can it still be used for research?
So I didn't hear the question.
Will it be helpful to have a sample from a latest patient, I guess a recently diagnosed patient? Can it still be used for research?
Sure. So most of the tissue we have is put into paraffin blocks, formalin fixed paraffin block, and we know we can retrieve that many, many years in the future, and we go back very often to old material. I think sometimes the family even ask us to go back if they would like to know something specific for their own genetic prediction. Yeah, sure, absolutely.
So just to quickly add that, I think many centers like ours do invite patients to give consent for biobanking. So at least we then got the tissue that can be used for research at some point in the future. So that's something that's very useful. With that, I'd like to thank our speakers and ask them to step down. Thank you very much.